Doctors take care of the ugliness in life, you know, from trauma surgery to severe neurological disorders. They're ugly and they're painful, and that's our doctor's job. And this is kind of a doctor of the psychic or the soul of the psychological issues, and that's part of our job. It is a mission. Not everyone can do it. Not everybody wants to do it. It's very hard work. We have a lot of psychiatrists who can't do it. I mean, simply cannot take a trauma history. It's very interesting that we thought people well trained could do it. They avoid it. And so it takes people who are comfortable eventually with severe, terrible stories and move on beyond that to help people without minimizing or discounting the terrible stories that they told, and they are bad. It really is bad. From this about massive trauma, I think there are kind of two examples, and they're at kind of different extremes. One is Cambodia, where it was auto-genocide, people killing Cambodians, killing Cambodians for 4 years. And that almost rivals the Holocaust in percentage of people killed of a percentage of a population. It's odd because it was not looking at Jews, but it was within the group, but out to get intellectuals and people who might be a threat to the new communist regime. That had both starvation and execution and no medical treatment. I actually visited Tol Sing, the prison in Phnom Penh, where they said 10,000 people were killed. I don't know if it was that many, but the communists at that time wanted to document that people were killed. So they had photos, and I saw a little room where they had a photograph before and after, and these people were not only looking quite dead, but also very bruised and beaten on their heads, because they could see that. And this was old school, and there is room after room after room of these photographs of these people who were killed. And they sometimes said that you're not worth a bullet, and so they would drown you or shock you or throw you in the lake with your hands tied and hit you over the head. The different kind of a thing is this random violence that happens, like in Somalia, where there's no government. Lower wards run the place, and people run wild and steal and beat and kill in a kind of an arbitrary, or at least random way, and in a very sadistic way. Case after case of coming into a house, wanting the money, there's no money, then, threatening, and then shooting the men, raping the women, children running around screaming, sometimes shooting the children. Sometimes the children, then they have this long walk to a refugee camp, sometimes three weeks or more, without food, without much food along the way. Also subject to further robbery and beatings and rapes. So that's an example. I asked several Cambodians, they don't ask anymore, used to, what was the worst thing you ever saw? And, one of the people said, I woke up at night and I heard thugs, thug, and screaming. And babies were pulled from the mothers, swung around to hit the head on a tree to die. And that's what he was hearing. And you could do nothing about it, and mothers screaming. I don't know if some of these things are true or not. One woman said they marched off children by putting a wire through their hands so they wouldn't run away, and marched them off to die. Well, we first thought it was similar to depression. So a short-term treatment did get well. And we actually did that with Jim Bainline and I followed people for a year. They got better, and we actually thought that it was a very treatable short-term illness. They all got worse again. And we finally realized it's a chronic illness with exacerbations and remissions over time. And triggers will bring back the memories. And it took us a long time to understand that. And the model then we went from single episode depression to more like bipolar disorder or even schizophrenia. Chronic, long-term, they're going to get better, they're going to get worse. And that idea that the worst thing was when we tried to get people better and assumed they get better and should stop treatment. Put a lot of pressure on us, a lot of pressure on them. When we got out of that and said, you can stay as long as you need to, as long as you want to. We have no terminal plan. And as long as we're here, you're welcome. One of the worst experiences we had along that line was we thought we were going to lose the funding. And so we told several Cambodians that it looks like we'll have to stop. It's just like you took away their mother. Two of them ended up in the emergency room with documented hypertension. They all crying, and I never quite realized what we meant to them until that time. And my counselor Ben said, we don't do this again. We either close or we go on forever, but we don't put people through this kind of ambivalent or ambiguous situation. That was just too much. I remember a couple things. I remember angry at our educational system. It's kind of weird. But no one in undergraduate, medical school, or residency ever told me that this thing could happen. That people would treat other people this way. And you know, it's my own issue, but I thought, Jesus Christ, someone should tell me about this to prepare me for it. Of course, being in Vietnam helped, knowing that it could happen. So that was it. I took a lot of it home at first and had kind of vicarious nightmares, perhaps. That has dropped off over time, especially as a lot of them have gotten better, and I've got the joy of that. I first need to say that our counselors are the big key. We have a philosophy: one patient, one counselor, one psychiatrist forever. So you come in, you get a counselor, you see a psychiatrist, and that team, that group, works forever. I think that idea that you have the same doctor, the same counselor all the time is the big thing. The personality of the doctor and the counselor is the difference. I am totally opposed to all this information about technique, exposure therapy, cognitive behavior therapy. That's bullshit. What is important is the relationship and instilling hope of patients. So I write about this. The things are the patient has a need at some time to tell their story. The doctor has a need to listen, or has to listen. Many people can't. You have to provide continuity of care, and many systems beyond the doctors can't do that over a long time. You have to be able to understand, live with, work with evil in the world. And the patients often, even unspoken, how could this happen? Why would this happen to me? And there is no answer, but it is an important question. And being able to live with the ambiguity and uncertainty about that question, but tolerating it, saying it is a good question, and I don't know the answer, and I'm sorry, I think is one of the other things. Obviously, I can just say, reducing symptoms fast. We use medicine a lot fast. and it's very, very helpful, and it's way beyond psychotherapy. And once you get people not having nightmares and sleeping and less depressed, then they trust you. Then it's going to work, and that helps everything. My first session with all the patients takes about an hour and a half, and it is not to be trauma focused. If I can tell you that, do not be trauma focused. People have a life before trauma, have massive trauma over many years, many traumas, and they have a life after. So it's important to put this in a context. I really oppose to trauma-focused therapy, and you forget the person has a life before and a life afterwards. With sometimes there's not post-traumatic stress, there's ongoing traumatic stress in places where people live, or hearing about relatives being killed or damaged. So taking a thorough history. I think the trauma focus misses what's happening in life. Kids are failing in school. They can't get welfare. They can't know how to ride the bus. They can't pay the rent. The husband ran away. All the things that can happen, and they can't get medical care. All those things you need to work on. And that our counselors doing case management do a great job on that. We consider that part of our job. One other thing I'd like to say is that really helps is a sense of humor. Some of the groups have great humor. Africans love to laugh. And Bosnians have kind of like an American cynical sense of humor. And being able to, in a gentle way, use humor lightens the load. It's not hard. It's not difficult to come to see us. Sometimes it's even fun. We're not going to... We don't double cross you. We don't change our approach. We're predictable. And every time you see us, we're going to be the same. We're going to go with different issues, but we're not going to change our approach or our style or our personalities. So we're safe and predictable. I don't know. I don't know what's helped. I know I can do it better than I used to. For a long time, I was interested in Buddhism, and I did a lot of meditation and mindfulness, which helped. I saw a lot of patients get better, which helped. I read some very good philosophers on evil. Like one said something very interesting. He said, there needs to be some answer for the Holocaust, but I don't know what it is. And there needs to be some answer about this evil, but I don't know what it is. But it's a question. Clearly, there are organizations like United Nations on human rights commissions on torture, which take the political arena and try to bring governments to bear. It doesn't really help on a one-to-one individual, but it has to be done. Someone has to do it. I have people say, why don't you get actively involved, politically active? You can't. I don't think you can do both. I don't think you can hear these stories and be in presence with patients. It's a totally different kind of activity to be in front of a group and say torture is bad, evil is bad, and I can't do it. I have to keep directly patient focused on that. I think one thing that makes the difference is being a doctor. Your job is to help this patient, and keeping that in mind is very, very helpful, I think. Even though no one ever told us how bad it was and how difficult it was to be a doctor. Doctors take care of the ugliness in life, from trauma surgery to neonates born terrible malformations to severe neurological disorders. They're ugly and they're painful, and that's our doctor's job. And this is kind of a doctor of the psychic or the soul or the psychological issues, and that's part of our job. My comfort has changed, that is for sure. I also think I'm very good at it. which I didn't think at first, and I don't think I'm very good at a lot of other parts of psychiatry. I like people from other cultures. Every time I get a new group, I kind of look forward to it. The Ethiopians are my newest group, and it's interesting for me. Some Congolese are new. So I think I'm better at it. I also think there's a non-pharmacological component to this in terms of I say it's going to work. I say you're going to get better. By God, you better get better. No, but this installation of hope and confidence that I have, that I didn't have at the beginning, I think really does help. And it spreads along to the patients. I think all of us here who do this work feel that we're pretty good at it. And because we stick around, we like it. Well, I think you have to like people. They're all from other cultures, almost all. And I think you have to like people from other cultures. You got to be comfortable with Buddhists, Muslims, and it's hard after 9/11 to actually be comfortable with the Muslims all the time. Almost all the Muslims we see are very, very nice people. And the Buddhists, of course, are very easygoing in general. You have to be comfortable with that. You have to believe their stories. And we didn't at first. But you have about 3 in a row telling you the same thing. You say, well, maybe this happened. And then the evidence from journalists and other people, historians, come out. And it's very compelling. So you have to do that. You have to believe that. You have to be clear what you can do. You can't bring the country back. You can't bring the family back. You can't bring the government back. You can't bring the job back. You can't bring the people killed back. Be limited in what you promise. And I think that's one of the problems with some of these simple-minded therapies, that they're not clear what they can do. We say, look, we're sorry. We can't bring your husband back. We can't bring your country back. We can't bring your social network back. We can help you sleep. We can help the nightmares. We can be with you as you adjust to this country, and we'll stick with you. And we're there. So I think that, if I have to tell people, be realistic what you can do. And patients appreciate that. They appreciate honesty and integrity.